Okay. Welcome, everybody, to the now second podcast webinar that HSR.health is doing on topics that we work on and on topics that we relate to. Today, we're going to talk about antimicrobial resistance, also known as AMR. And that's because today is the end. It's Friday. Thankfully, happy Friday, everyone. Okay. Today is the end of World
Welcome, everybody,
Antimicrobial
to
Awareness Week. World AMR Awareness Week. You may have been seeing this on LinkedIn and news media outlets, but this is a week dedicated to letting everyone know that there is a substantial rise in antimicrobial resistance around the world, and it's not a universal or a evenly distributed rise. There are some areas with worse situations than others. And what that simply means is that infections that could be caused by a cut or a fall or a scrape can get infected by a bacteria that our current antibiotic medications, yes, penicillin and its collection of drugs, can't easily cure, which means that those infections can lead to substantial consequences, even including death. Yes, you will die from an infected cut if you don't get any treatment from it. I'm joined today by two wonderful AMR professionals. Amanda McKiston. Did I say your name right, Amanda?
Good question, but close enough, honestly.
No. We're going to say it right. Amanda McKiston. She was a public health analyst and an expert on antimicrobial resistance, has done a great deal of research, and is the author of our white paper that you may have seen on our website or on LinkedIn on antimicrobial resistance and some of its underlying factors, which do stem from pharmaceutical drugs or the lack of new drugs, all the way to environmental and economic issues as well. She's also a student at the Milken Institute of School of Public Health at George Washington University. And Jill Mikowski, who's actually, I'm going to let you introduce your current position because you've got some news to share on that front, but as also an AMR professional. Go ahead, Jill.
Thank you. So I am currently a clinical pharmacy specialist in infectious disease. I've been in that role for 11 years. I've built up our antimicrobial stewardship program at the current community health system that I'm at in Massachusetts, but currently transitioning in 3 weeks to a new position in compliance. So antimicrobial stewardship really is like compliance for antibiotics. And so it'll be probably a smooth transition, just a broader playing field for me.
Congratulations.
Thank you.
And that is truly fantastic. And so I'm going to start right there, kind of, Jill. You said that AMR stewardship is like compliance. So what is it that antimicrobial resistance stewardship does, and sort of why is that even needed in a hospital setting?
Well, it's a Joint Commission requirement. So if you are a Joint Commission certified institution, it is required that you have an antimicrobial stewardship program. So what that is, it is a group of our infectious disease physicians, administrators, infection preventionists, microbiologists, and antimicrobial stewardship pharmacists, as well as some operational team members that get together and review our antibiogram, which is the rate at which bugs in our community are effective or ineffective to our susceptibility to our antibiotics. That gets published annually. And we look at where we're slipping, where our antibiotics aren't working as well, and how we can change policies either on dosing, on usage, on restriction to make our antibiotics last longer and act better for our patient population. So we look at that antibiogram and construct it every year and make changes to our policies to help providers choose the best coverage for their patient, in addition to doing at the elbow education each and every day on patient cultures that are resulting, so that we can get the best outcomes for our patients. In a nutshell. So it's very much like compliance, because you're sharing the information that you have from our current community system, educating and training the professionals in our system to do the best thing based on those results and on standards of care, and then enforcing and re-educating and monitoring constantly and auditing and then giving feedback.
Yeah.
It has a lot of compliance components.
It does have a lot of compliance components, and I'm assuming that you see a lot of compliance with the essentially restrictions on the use of antibiotics that the stewardship program generates.
We do.
But sort of what I was getting at, and Amanda, feel free to jump in anytime, is yes, it's a Joint Commission requirement, but why is it necessary, right? So everyone now has sort of grown up in the post-pandemic, but I'm sorry, post-penicillin world. All right, that's a slip, right? In the post-penicillin world, where we know, oh, you just take an antibiotic, it'll be gone in a few days, right? When did that start changing, or really has that started changing for masses of people?
It has. The antibiotics that we currently have susceptibilities that they were tested against when they were new. And as we use them, they get smarter and they gain resistance. So normal in the original penicillin era, it would take antibiotics somewhere between 22 and 24 months to gain resistance to your antibiotic. And now they are getting smarter and their resistance patterns are getting more broad. And we see resistance if you're using an antibiotic where it's not indicated, you can see resistance in 12 to 14 months. So that's a lot shorter and that's a lot more dangerous because the antibiotics that we thought worked or used to work won't work anymore.
Right.
And technically, if you look at what the literature says, it says that by 2050, we'll be in a post-antibiotic era where we have more bugs than we have antibiotics to treat them. And that's not that far off, and that's a little scary. So we're trying, as a hospital system, as most hospital systems that have antimicrobial stewardship are doing, to not have that happen.
Yeah. So, and you're saying that part of the reason is that when you use an antibiotic which kills bacterial agents, those bacteria, they're living life forms. They have evolution. They evolve. They develop resistance. The more exposure they get resistance. But your stewardship program, like all stewardship programs in hospitals, really only works on prescribed antibiotics to patients in the hospital setting. But that is actually just one area, right, Amanda, where exposure to antibiotics and the bacteria they kill is taking place, right? Like you mentioned in the paper, there's a lot of use of antibiotics in the farming and animal husbandry world.
Correct. So veterinary antibiotics or antibiotics used in the meat/poultry industry, which are typically used kind of like as prophylactic agents or feed adjuvants, so in conjunction as growth promoters for our animal products. And typically there's approximately 80% of annual consumption of antibiotics occurring in food animals, within major countries being required to meet the growing demand for the population. So while on one end there are people who are hungry, we need to feed the masses, but on the other end, we keep using these antibiotics, and a lot of the times the living conditions for these animals are not very good. It can further promote what we're seeing now with antimicrobial resistance.
Do you think, and this may be hard to answer, right? There may not be statistics on this, but do we really think we need to pump up our livestock so that they produce or generate quantities of food needed for the population? Do we need to pump them up with antibiotic drugs to accomplish that?
I would argue, because obviously there is a growing demand for people to consume meat and poultry, but I think the standard American diet is so focused on animals, like animal-based foods. I think if we changed our diet, and of course this would be very difficult, to just being a little bit more plant-focused, because obviously nothing's ever going to be perfect, but just reducing that, we could save a lot on water consumption and just emissions, as well as help with antimicrobial resistance, because I feel like all of these issues are very much intertwined.
Yeah. And do the raising plants for consumption, does that not require the same level of antibiotics and pesticides in water as animals?
I would say there is to some degree, but I think doing it in a more sustainable manner, having the animals live in better living conditions would help to offset that.
No. Are there other sources where bacteria achieve resistance?
Yes, so another source would also be like the overuse or overprescribed antibiotics in healthcare. I feel like even myself, like there have been times where I had a viral illness and I was still prescribed antibiotics and I took them because I decided to listen to my physician, but I wasn't really entirely sure why I was taking this when it was a viral infection. And normally when I was told it was to essentially like clean me out for antibiotics or just kind of like to reset my system. I have no idea. But I think, in a study that was conducted by Washington University and the Pew Charitable Trust, they found that unnecessary use of antibiotics prescribed to children resulted in $74 million in excess healthcare costs in just 2017 alone.
It's actually very high. In outpatient prescriptions, I think the last data I saw that it was over 70% of prescriptions that were written were not properly either written. So they were written for something that wasn't going to be treated with an antibiotic, or it was the wrong dose, wrong duration. All of those things lead to resistance, and that's concerning. I think it's a lot of education to the population too. People bring their child to an urgent care because the child has a cough or a sneeze, and they don't want to hear that it's viral and antibiotics won't work. They don't feel, if they don't leave with a prescription, they don't feel that they were treated. And so
Right.
educating the public is really important about expectations and how antibiotics can have negative consequences as well. They can have side effects, they can have resistance, patients can get C. diff for overuse. So there's a lot of risks to antibiotics that people don't realize. So educating the public, like you had said, you were personally concerned and took it anyway. I mean, I think letting people know that it's okay to ask your provider if that's really necessary, or if you have to take it that long, and have them think about their prescribing patterns. We're trying to also talk to our urgent care providers about doing like a watchful waiting. Like, this looks viral to me. I'm going to send a prescription to your pharmacy, but I want you to wait 24 to 48 hours, see if you feel better just with fluids and Tylenol. And if you really feel you needed to pick it up, then you can pick it up later, kind of thing. So
Right.
that maybe they don't actually wind up with the antibiotic if it was just in the moment they were feeling terrible and dehydrated, and a little bit of fluid and a little cough syrup or something makes them feel better and they don't actually need to take the antibiotic.
So you used a medical term there as one of the side effects. You said C. diff. What is that,
Yes.
Bill?
So Clostridium difficile infection is a GI infection in which where bad bacteria, the Clostridium, is overgrowth. It results in diarrhea that's pretty severe, and dehydration can be a result. People do get hospitalized for it. It is hard to kill. It's very infectious, and it requires then antibiotics to kill the Clostridium in the gut and allow the gut to rebuild its normal flora. And
Wow.
it's a huge, I mean, the microbiome and how it relates to health is a big issue nowadays. And this is a very dangerous side effect.
So then I'm thinking one takeaway from this webinar, and maybe all of World Antimicrobial Awareness Week, could be if the statistic you said was correct, even if your statistic is 50% off, if 70% or 35% of all antibiotic prescriptions are wrong, then anytime a patient receives an antibiotic prescription, it's probably worth a question to the doctor, right? We hear that 70% are wrong. Are you sure we should take it right now, right? Just, let's think it through one more time, because there's so much error and there's so much consequence for antimicrobial resistance. That's probably something that we should ask patients to do. And to some extent, I'm kind of surprised, right? Because in this world where all patients have a medical degree because they've got Dr. Google or they have ChatGPT right on their phone, they should be knowing the statistic that 70% of antibiotic prescriptions are potentially the wrong course of action. Why
They
aren't there
might,
more?
but antimicrobial stewardship, sometimes I feel like Chicken Little. So sometimes I feel like it's coming, and if it's not happening to them in this moment, they don't feel like it's happening. So the same thing, patients might read that and they might think, well, that's to other people. That's not my infection. That's not my child that's sick at this moment, and I need to do something about it. So they might feel like that in the broad scheme, but it doesn't apply to me. But I think empowering people to ask questions is a very healthy avenue.
Correct. I mean, we say that, right? Advocate for yourself. Do ask questions when you're speaking with your physician or any healthcare provider at all. Yeah.
I had a patient that came in. So I work at a medical practice for dermatology as well as plastic surgery. And I had a patient who I was just talking to, kind of just small talk at the front desk. And they had MRSA that they contracted from, I think, their gym. And they had no idea that that was like a common place you could contract MRSA. And so we had this whole conversation about antibiotic resistance and how just it can happen to really just anyone. You just never really know.
Right. And there are people too that, walk around with bacteria either in their skin or in their gut or in their urinary tract that are not infectious. They're just colonized. So because you're colonized, if you don't have any symptoms, especially in the urinary tract, you don't need to treat it. So the important thing is treating the patient, not the lab. Just because the culture comes back, especially in a hospital setting where somebody has a fall or somebody's dizzy and we're testing everything, it doesn't mean it's infectious and you need to treat it. So helping doctors make that distinction between whether the patient has symptoms and you need to actually treat, or whether it's just a colonizer and it just lives in their lungs or in their gut and they don't need to be treated. It's an important distinction as well. So the person that got the MRSA infection, I take it was a skin infection?
Yes. And they got it from like working out. He's like, I had no idea you could get this from working out at the gym. And I'm like, it's actually a very common breeding ground. That's why they should have more wipes out at the gym.
They should, and people should use them.
Wait, hold on. Let's back up a little bit. Maybe I missed that, but because I like to consider myself a person that works out at the gym. Now you might see visual evidence to the contrary, but how common is it? The gym is a common public place. Lots of people are there. There's supposed to be some level of cleaning. We're saying that even these places are now infected with antibiotic resistant, bacteria.
Yeah, I mean, they instruct people to clean the machine after you get off, but if somebody didn't and you're getting on, then whatever. I mean, even if the gym is clean, even if they clean every day, that's a whole day's worth of people going in and out and using machines that may or may not get cleaned in between. So anything that winds up on their hands, that winds up on your hands, that winds up, you touch your face, you touch your nose, you touch your eyes, it winds up on your skin as well.
Wow. Well, that's obviously that's very scary, right?
Yeah, and there are some organisms that will live outside the body like that and can be transmitted, and then there are some that aren't transmitted that way, or as soon as they hit the air for a certain amount of time, don't survive. But unfortunately, the person that Amanda described did pick up MRSA in that way.
Yeah. So let's paint the picture then, right? You said earlier, Jill, the globally accepted statistic that we might be in a post-antibiotic world by 2050. And we've now talked about the fact that bacteria, of course, are microscopic. They are everywhere. How realistic is it that a regular person minding their own business, just doing all the normal things that people might do in the course of a day, how realistic is it that they are going to be exposed to and potentially become infected by a resistant bacteria?
I think, if they're a healthy person with a good immune system, they might come in contact with something, but it won't infect them. If they're healthy, if their skin is in good condition, if they're clean and they have the opportunity, live in a country with clean water and have the opportunity to, eat healthy food, then their chances are less of being infected. They might actually, be infected, but they wouldn't contract it or get sick from it. Whereas you have countries where they don't have clean water, they don't have opportunities to eat healthier food, they don't have the opportunity to wash and stay clean as other countries might, and that puts people more at risk. You have immunocompromised patients who are on either treatment for long-term conditions or cancer that their immune system is being affected by the treatments that they're under and make them more susceptible. You have older people who lose some of that immunity or are further from the vaccines that people get. You have people who don't vaccinate their children, as ACIP is recommending. So people become or are born with conditions that make them more susceptible than other people.
Wow. Well, that's quite a lot. And, you said at the beginning of that the economic conditions are a predictive factor.
Yes,
Amanda, have
social
you?
determinants of health are huge. People who have access to healthcare, it's another issue too.
Wow. Amanda, are you seeing, did you see that in your research that there are the pockets of antibiotic resistance mirror pockets of poor economic outcomes and socioeconomic status?
I would say so because there is a lot of there's a lack of patient education in regards to antibiotic use. I mean, I've seen on social media where people would hold on to their antibiotics, like in the event of like them having another infection, just because it's so hard for them to see the doctor again. Or maybe they won't finish their antibiotics, which is again a really great health risk.
Right. And if those people even have access to the same doctor. So if they go to urgent care because they don't have a PCP, that doesn't mean they'll get the same provider at that urgent care who knows them, who has any kind of established relationship with them, that, had done any testing or is even familiar with them again. I actually, when I worked in retail, I had people who were afraid to bring their prescription to the retail pharmacy because they were afraid that they weren't in the country legally, that they'd be
Yeah.
reported, that somehow this would be like, going to the federal government. The retail pharmacy is the one place where you can have access to a healthcare provider without even paying. You can go and ask the pharmacist questions and it's their job, to assist you. And so it was really sad that these people were even afraid to bring their prescriptions to the counter.
Well, that's part of this, why this is World Antimicrobial Awareness Week, right? Because it is not necessarily constrained to those hotspot regions even, because we are so mobile and so many of us go to so much of the planet that, just simply more than a decade ago, more than a generation ago, that this has now become a global problem, right? So the 2050 number, it's not like everybody might become post-antibiotic all at the same time, but that staging process may not be that long.
Also, right. And as we saw in the pandemic, something that happens in one part of the world, the way people travel nowadays and how accessible air travel is, can move very quickly throughout the world.
Absolutely. Absolutely.
Something that I did find very interesting in your paper was how it talked about climate change and changes in, the growth and the earth and things that are happening with the animals that in, clinical hospital systems, we worry about our patients and the things we can control. These are so many things that we can't control. So I think that's a really important point to make to my providers, how important it is that we focus and we're committed to the pieces we can control because of the issues that we can't. That I thought that was something that we don't normally educate them to.
Yeah. So what do you think we can do about that?
Well, when it comes to the issue of climate change, there's so many different factors in regards to addressing, because what's going to happen and what we've been seeing is just the occurrence of more frequent extreme weather events, which is going to yield more pollutants in the water and soil. So that's just perfect breeding ground for bacteria and bacterial resistance. People are fleeing and moving other areas, so that can also further propagate this as well. I think the first thing is just starting off with awareness and advocacy, because I think knowledge is just so much power in regards to climate change. And then from there, making better policies in regards to looking into extreme weather events and investing more time in research as well. There's just so much that we just don't know.
I think it's true, very much so. Like even in a country like the US, I heard that yesterday, Asheville, North Carolina got clean water for the first time in 50 days.
Right.
And so that's in a first world country that has, access to all of the best engineers and, water systems. And I can only imagine how a devastating weather event in a country that already was under a lot of stress, economic or, population or war or whatever else is going on, how it would affect them and how long those people would be without clean water.
Can you fill in the gaps for people who might not know? What's the connection between clean water or lack of clean water and antimicrobial resistance?
Oh, well, think of countries where animals bathe in the same water that people use to drink or cook. You know, how that transmission of stool or whatever it's coming off those animals can transmit right into the people. So having clean water, I mean, is just the transmission of bacteria from animals to people or soil to people or person to person is huge. I mean, look at the times when there was diphtheria and cholera in all these countries that don't have clean water systems. Those are still problems.
Wow. And so we should be grateful for our own clean water, which we know, which we take for granted. But as you mentioned, one hurricane, although yes, powerful hurricane and kind of an unexpected area to be hit by a hurricane, and for 50 days there wasn't clean water.
It's very scary.
Yeah.
Also, I mean, if you think about it, not that it's so much a stewardship issue, but Baxter, one of our IV fluid companies, had a factory there. So we have been dealing with shortages of IV fluids in hospital system all over the country because their factory was affected by the hurricane and clean water supply there.
You know, that I wonder if that should be an area where stewardship should be involved, right? So clearly your domain in a hospital is hospital prescriptions or hospital prescribing. But if this issue is impacted by a medical supply chain, if it's impacted by the meat and poultry industry, then maybe we do need to have a broader oversight of bacterial exposure to the drugs that we need to save our lives in an infection situation.
Well, I believe there is. I didn't attend this year's conference that we had, the Antimicrobial Resistance conference, to talk about. I know there were lectures that talked about animal use of antibiotics, and I do believe it's fairly regulated, but I think it might be state to state. So I wonder if that's something that could be more broadly educated to.
Right, which comes back to the economic issue, right? So if the use of antibiotics in the meat and poultry industry is to produce more food, which I'm sure is they're making an economic argument that they're producing more food at a lower cost point, so that saving can go to the consumer. That's probably the justification used to continue the practice, even though there is a resistance component to it. Because I'm sure if a bacteria gain resistance through our use of antibiotics, they also gain resistance through animals' use of antibiotics, which only means that the animals have to be pumped with more and more antibiotics with time to have the
Right,
same
because they
effect.
gain resistance as well, same way.
All right, that's not looking good. Maybe we shift the conversation to what kinds of things can we do, right? So, Jill, in your program, have you seen benefits from stewardship?
We have. So our stewardship program has been in place for 11 years. In the first year that we came on, we did our antibiogram and realized that we had some antibiotic classes that are supposed to be effective against certain organisms, and they weren't because of the overuse. So the first thing that we did was restrict them. Tell providers you can only use them if you absolutely have proven sensitivity, because other than that, empiric use is not safe because you don't know that it's treating it.
Right.
So in one class, the fluoroquinolones, which were quite overused at the time that we took the program live, we were dosing about 2,200 doses a day. We have a hospital system that's about 800 beds. 2,200 doses, maybe it was a week. Either way, it was supposed to be sensitive to a strain of Pseudomonas, which is a pretty powerful gram-negative organism that affects a lot of people in our community. And it was only about 60% sensitive. So doctors were using them because they thought they were getting coverage that they weren't getting. So we restricted it. And in the decade since it's been restricted, probably been restricted about 8 years of the time that we've had the program, we now are up in the 80% sensitivity range. So it did take a long time to regain some use, but at least we know our patients were using agents that were actually treating them and not using agents until they were proven
All right, that's a lot there. Hold on, couple things. When you started at looking into creating the first antibiogram, you actually discovered resistance that practicing clinicians who see the patients before, during, and after treatment did not know existed.
Right, because the literature says that, in general, this antibiotic should kill this strain, but that is a figure that's published at the time the drug comes to market,
Right.
that it should work. But the important thing is the small print. Anytime you read standard of care, it will say use of this drug is recommended by the standard of care if your resistance patterns is less than 20% in your community. So most providers weren't educated to the fact of what the resistance patterns were at the time. So the antibiogram was being published for years before, but how much education was actually trickling down to the people who need it and use it was one of the shortcomings that we found.
And the clinical teams didn't notice that it's not working as expected. I mean, that's not a thing that would be obvious.
They may have, and they may have changed therapy a couple of days in when they realized it wasn't working, but that's still a couple of days that the patient wasn't getting the treatment that could have been more beneficial. So they may have changed after they saw that, oh, this patient's not getting well as that quickly as they should be, but we can even save those few days of exposure if we can do it right initially.
Correct. And even in some of that, and no doubt some of that took place, but it took a concerted effort to create an antibiogram for this to become institution-wide guidance.
And to do the education and to make sure everybody understood what you're showing them.
And then on a positive note, towards the end, you said that after 8 years of this guidance in the restricted, more appropriate use of this drug, resistance returned, or I guess the resistance went down and the drug became more effective again?
Correct. So it rebounded its usefulness, not entirely, but 20% is really large.
It's a huge jump for 60 days.
Yes.
So does that mean that the bacteria forgot how to fight the drug?
We stopped exposing it to it. So the generation of bacteria that knew how to kill the drug, died off. The new bacteria weren't exposed to it, so they didn't know how to fight it again.
Well, that is a very positive note, Amanda, right?
I didn't realize that it could kind of rebound, but it makes sense because if there's no bacteria to transfer over the genetic information, then obviously it would eventually die out. So it's interesting that it's only just 8 years.
Right, not that long. Right, that's true. Although generations for bacteria are very, very small period
quick,
of time.
Right? Their lifespan is not large. And we were dealing with between 2,200 doses a month. Now we use less than about 200.
So that's actually a note of substantial optimism, right? That it almost seems then, because I think when people learn a little bit about AMR in general and thinking that bacteria gain resistance to a drug, that once that happens, that drug's gone forever. But that's not necessarily the case. So we may not always just need new drugs, although there's a role for new antibiotics, but maybe we use rotating drugs.
Some people do that, I've heard of systems that do that. That does take a lot of strategy, and also think about your buying groups, a lot of education. Is a strategy. It's just a difficult one to pull off.
Well, I don't know that what you have described is any different, right? So you had a drug, it was in use, you found it's not necessarily as effective as it should or could be, and you restricted it. So you must have made something available, or it's not like those patients simply didn't get an antibiotic, although
no, that's true. There are other drug classes, right? There were other drug classes that did work for that. So we just educated them to the other resistance rates, which were much better, and the argument of proactive, or every time something was ordered, we got an alert and we had to educate. So in addition to the fact that we took it off order sets, I mean, it was a project, but over time, it's become easier.
So there's hope that 2050 will not come and usher in a post-antibiotic era.
Right. We hope so.
Right. Right, at least the contributions that healthcare can make, right? Because we can't control the weather, we can't control natural disasters or the lack of availability due to a natural disaster of water and other sanitation. We can't control the animal and meat and poultry industry. We can only control, I suppose, to some extent, the creation, generation of new antibiotics and the use of existing antibiotics. So it looks like in the use of existing antibiotics, there are solutions that have demonstrated to work for populations, right? Maybe potentially expanding that to a rotating set of drugs over time will be even better. But why is there, it seems like if these are life-saving drugs, that they should be valuable. So a broad note, Amanda, why is there such little development and research and development into new antibiotics?
Yep, so there is an estimated rate of failure in creating antibiotics. It's approximately 95%. And a lot of the reasons why these biopharmaceutical companies just don't really find it advantageous to produce more antibiotics is because antibiotics are typically prescribed to people who only take it for just like a few days. And then, of course, like the looming issue of antibiotic resistance, it's not very much financially advantageous for them to spend decades of research investing in creating a new antibiotic when they could work on all of our other non-communicable diseases such as diabetes, hypertension, things that people will be using continuously for a long time.
I guess that confuses me, right, to an extent, because if you don't treat an infected wound, you're probably going to, depending on the severity of the infection, die in a short period of time. Wouldn't we think of that as high value medication? Or is that just not how the economics of pharmaceuticals work?
I would say it's more so down to the economic aspect. Of course, we should always value saving people's lives, but if they're only going to be using the medication for a short period of time, it's not going to make much profit as opposed to creating a drug for any kind of chronic disease.
Right, right. Which means the alternative is that we have to allow for these drugs to be very expensive since they're only going to be used a few times, right? What is the general price point for antibiotics, Jill?
It's low.
Yeah.
Think about it like you go to pick up a prescription, you pay your copay, whatever it is, it might be low, but for the most part, you have 17 years on a patent, even a brand name drug. So, the newer stuff is more expensive. The stuff we use in the hospital that's IV only, it's more expensive. Plus you have to pay for nursing time, pharmacy mixing time, all of that stuff. So, but as far as the hospitals go, they bill for a DRG, and whatever gets used has to get covered by that amount. So it's not like the patient sees the price of it.
True. So there's a regulatory angle there, right? It's covered within the DRG. So maybe there's room for, especially if we do get closer to a point where it's truly potentially antimicrobial resistant world, that we have new DRGs or raise the reimbursements for existing DRGs to reflect the severity and expense of the drug that needs to be administered.
Sure.
Yeah, I'm sure regulators are out there loving that conversation, right? Oh no, they have to raise the prices of something because we know healthcare is so expensive already too.
Mm-hmm. Yes. So as we see more resistant organisms, we need to add more expensive, more selective antibiotics to the formulary, and that's more expensive for the hospital system. But you have to be very careful and selective about how you use them, because gaining resistance to the newest agents is not going to leave anything and that's a scary conversation to have when your infectious disease physician gets a culture back and they want to discuss what's an option, and you tell them, I'm sorry, we don't have any options. That's a terrible conversation to have.
Well, that's also not how healthcare is supposed to work, right? And now we know that obviously healthcare is delaying the inevitable. Eventually, it can't save everybody from everything. But in this scenario, you have an infection. Are you saying that you see often, hopefully not often, in patients coming with infections that you simply cannot treat?
Not often, but occasionally. And I hope it never becomes often. But that's what that 2050 conversation is about.
Right. So in those cases where you have a patient with an infection that you cannot treat, what's the prognosis?
I guess it depends what kind of infection it is. If it's like a skin and soft tissue infection, then you just continue to have surgery, try to clean it out, have nursing, um, wound care nurses continue to try to treat it and get the infection actually off the skin, if that's possible. Sometimes if it's skin and soft tissue or bone, it leads to amputation. If it's in a vital organ, lungs, CNS, and there's really not a lot of options you can do. You can use combinations of drugs to try to raise their potential of each other so that they can work together. And maybe even if they're individually not entirely susceptible, if they're intermediate, that they could work together to help. Or you wind up going with experimental studies if you can have a big educational center that is on a study for a new antibiotic, that maybe they would take the patient in as part of their
As
study.
part of a trial? Yeah, so that may very well be a relatively good approach, right? Obviously, the trial means that they're trying something out, literally, and it may not work because that's what experimentation with trials mean. But what we're seeing from the drug manufacturer's perspective is that it's hard to make antibiotics. The failure rate is high, maybe higher than other areas. Then to protect the efficacy of the antibiotic, you have to actually not use it. Then it's not that expensive, the drug, so the reimbursement, the payoff for that drug is smaller. And of course, these are powerful weapons that can have side effects if they are misapplied.
And these bugs and the patients that come in with multi-drug resistant organisms generally have a lot of antibiotic exposure in their past. So being really judicious about the use of your antibiotics early on should reduce the opportunity for these multi-drug resistant organisms to show their face.
Okay.
I also read that hospitals tend to stockpile like antibiotics that are like newer to the market or that have not been used. Would you say that that is like common in most hospitals, or would they ever like use them in a scenario like this?
I wouldn't say it's common because most of them are so expensive, it doesn't pay, and they don't last long, right? They all have a shelf life. So I wouldn't say that I've been in a hospital system where I see that. I would say that especially at the price point that most of those newer agents are, we definitely do not do that. We have 3 hospitals in our system, and we even share between the hospitals. So if there's an agent that we need for a specific patient here or there, we'll tell our ID infectious disease providers, one of the hospitals will have it. So if you need it, just let us know and we'll pull it from one to another, because they're too expensive for each of us to have any kind of stockpile like that.
Yeah, that's we have to share resources in healthcare, right? There's just no way around it, right? And that's true sort of throughout. There's competition, but if a patient needs to be treated, we share. I mean, that's how the sort of the Children's Hospital Network works as an example, right? That any hospital who's not a children's hospital has a complex children's case, they were going to send it to the children's hospital, right? But so we had a moment of optimism here, Jill, when you introduced the fact that your antibiogram and stewardship program helped make an existing drug more effective, right? And that was great. And then we went right back into the topic, and it's pretty dark, right? The potential future of the use of antibiotics as a opportunity or a treatment avenue for infection, bacterial infection, seems bleak. So if I ask you sort of an exit question on this front, does this mean that, well, first of all, I want both of you, and I'll certainly share this too, what's our view of the future look like for with respect to antimicrobial resistance? But could it be that the use of antibiotics to treat infection is maybe the wrong approach, that we got to come up with a whole new approach to fighting bacterial infection?
Well, I think that the importance of education around source control is if you do not control the source of the infection, antibiotics are not your answer. They're not going to help. So I think early recognition of where the source is and how to control it, whether it's an abscess that needs draining, whether it's, a skin and soft tissue that needs cleaning out, and the importance of source control, and also recognition of what's infected versus what's colonized, and only treating once you have those factors in place.
And if you do that, then the likelihood of what's the gain from doing it the right way that you're describing?
Well, you're not going to give the bugs within the source that's not controlled opportunity to look at the antibiotics and learn to work against them before you even have source control.
Got it.
So if you have an abscess that's full of organisms that are going to hurt this person, and you don't clean out the abscess first, then you're exposing those antibiotics to organisms that can learn to work against them before you're even at the point at which you should be using them.
Got it. Right. Okay. So treat and then kill. Really.
Right. Antibiotics can't do it all. There are certain things that we try to manage with them, but you need to actually have source control first.
Amanda, same question to you. Do you think that your research suggests that maybe antibiotics is the wrong approach if their lifespan is so limited? And what do you think of as the future for AMR?
I would say it is very much dependent on education and awareness and just limiting our use. Like a few years ago when I was doing research, I think it was like an undergrad, I had read a lot about bacteriophage and how it could work to lessen the burden of antimicrobial resistance. I think there are definitely opportunities for research into alternative therapies out there. Of course, only time can really tell. I think right now we have to focus on like the present, which is minimizing the burden, looking education, stewardship. But I think, it's always good to put all your eggs in different baskets. That's what I like to say. Oh, I think you're muted.
That's definitely one of the category of first world problems, right? The mute button seems to hit itself sometimes. But yeah, I've heard of that too. The concept of the phage, which is something that eats bacteria, right? That maybe that is. There's only one country in the world that has an actual bacterial phage program, the country of Georgia, but that might be an alternative to the use of antibiotics at all if there's so much issue with antibiotic use, which again, healthcare can only control a portion of the use, right? We didn't even talk so far today on the fact that we have antimicrobial agents or antibiotic agents in so many household goods that we use, right? Even a lot of hand soaps have antibiotics in them, which gives opportunity for bacteria to learn and gain a resistance. But if I'm an optimistic person, so I definitely think that we're not going to end up in a post-antibiotic world. Not because we cannot. I definitely see that if we let ourselves continue down the road in the manner that we are now, that it can happen. But I don't think it's going to happen. The fact that there are AMR stewardship programs at hospitals like yours, Jill, and that the fact that you have seen tangible positive results does suggest to me we'll figure out a way around it, right? Because ultimately, the society is not going to be served by reducing our ability to help us stay alive, right? There's no way to look at it and say like, hey, that by having a whole lot less people not only able to live, but able to live healthily, right? Because you said some of the consequences of infection could be amputation, right? You can't live a full life if you have to have something amputated, and not in the same exact way, right? And so I think we'll find a solution. And the things like this, like Antimicrobial Awareness Week, to some minor extent, our white paper and this webinar help to raise awareness for the people that watch, that view, that tune in, or even that just skim the paper. Hey, there's something that we need to do a little bit better job, whether it's question doctors when you get an antibiotic prescription, just because it may not be perfect, whether it's, hey, I can actually just reduce my own exposure by staying healthy, keeping my skin clean, and watching the wiping down the gym equipment after I get off the gym equipment. Small things like that can make a difference. Then let's be optimistic that we won't be in a post-antibiotic world. Jill, any last thoughts?
No, I just think that Amanda's right, that education and sharing the knowledge of antimicrobial resistance and the opportunities that stewardship have, and making everybody a steward is really going to help, and advocate for yourself. I really appreciate the opportunity today.
Amanda?
Yep, I'm so grateful to be here to talk about this issue. I think doing my research and reading about all the issues that pertain to antibiotic resistance made me feel a little bit depressed. It was very grim, but then hearing about how in your case, how that antibiotic rebounded its sensitivity, it makes things a lot more hopeful for the future that we can reverse this.
Yeah. So this is an annual week. World Antimicrobial Awareness Week is annual. Maybe we'll come back in a year and get a status update. I know you'll be, Jill, in a new position, but you'll still be doing some compliance work, and then just to see where the world is and what's going on with AMR. Hopefully, we'll have positive progress to report. And with that, I thank the audience and thank everyone for joining, and that will conclude our second webinar podcast on health issues. Have a nice day and a wonderful Thanksgiving next week, everyone.
Yes.